Hello, everyone. I'm Jessica Goldstein, Education Program Coordinator at ASRM. Before beginning the webinar, I'd like to go over a few housekeeping items. To make sure we can cover all the content in the allotted time, everyone's line except the speakers will be muted. We will devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question in the chat window at any time. We will then read as many selected questions as possible to the presenters during the allotted question and answer time at the end. If for some reason you need to step away from the presentation, please sign out and then sign back in on your return. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notifications. To introduce our speakers today, I will turn things over to Professor Judith Darr.
Welcome to those of you who are in the United States and those of you who are joining us from abroad. It's just my absolute pleasure to present the second in what we hope will be a long-running series of webinars presented by the ASRM Ethics Committee. And we are endeavoring to present to you material through this webinar series on a quarterly basis that focuses on the myriad ethical issues that present in the practice of reproductive medicine. Today's topic grows out of discussions that we've been having on the committee now for several years that ultimately culminated in the report that we recently published in Fertility. The report is titled Access to Fertility Services by Transgender Persons. And this document we take a great deal of pride in, as we do all of our documents. And it really provides us the opportunity to share with you various aspects of care for this particular patient population. So to present the material, we're just thrilled to have three excellent speakers, two particularly excellent, myself excluded from that, but let me introduce them in the order in which they'll present, and then I'll wrap up with just a few additional matters before we get started with the content. Our first speaker will be Jean Ford. Jean is a psychotherapist and program consultant whose practice focuses on adoption and fertility issues. She is the past chair of the ASRM Mental Health Professionals Group and also former president of the Sperm Bank of California. She currently practices in Northern California, and her practice includes consultation for fertility patients, gestational carriers, and gamete donors. And we're so thrilled to have her as part of our ethics committee, where she largely shepherded this policy from beginning to end. Our next speaker is Paula Amato. Paula is a reproductive endocrinologist who holds the rank of Associate Professor of Obstetrics and Gynecology at Oregon Health and Sciences University in Portland. Dr. Amato is Director of the oocyte donation program and has a large LGBT family building. Is a dear colleague who spent many years with us on the ethics committee, and I'm sad to say she's a former member, but only because she has taken on a very big role. She now currently serves as one of the ASRM Board of Directors. My name is Dar, and I am a professor at Whittier Law School and a clinical professor at UCI Irvine, University of California Irvine School of Medicine. I've been on the ASRM Ethics Committee since 2008, and last year in 2014 was appointed to chair the committee, which I proudly do. All right, a few matters before I turn it over to Jean. The way that we will proceed is that each of the three of us will speak for about 12 to 15 minutes, and we each have PowerPoints that will guide us through our presentation. And as Jessica said, we welcome questions, and you can type in your questions in the chat window in the bottom of your gray toolbar, which should be showing up on your screen. And you can do so at any time. And Jessica will be monitoring the questions, and we will answer as many of the questions as we can as time permits when the presentations wrap up. And if I may, I'd just like to take a minute to let you know about our next webinar, which will be the third in our series, which we will on March 10th, and we have three speakers lined up for that as well, and the topic will be dilemmas in embryo and gamete disposition. So we look forward to seeing many of you back again for that. Thanks everyone again, and with that I'm going to turn it over.
Thank you for that introduction. Today I'm going to talk about the nature of transgender identity, the ethical concerns in providing fertility services to transgender patients, and talk about what we know about the welfare of offspring of transgender parents. Over the past decade, public awareness of transgender persons has increased dramatically. I'm sure many of you have heard about the Amazon show Transparent. But most of what we see depicted are transgender persons who already have children. What about transgender persons who have no children, want to become parents after transition, and need assisted reproduction to do so? What are the issues? The central issue is whether it is acceptable to help transgender persons have children. And if so, do programs have a duty to treat all transgender persons? We identified four major ethical areas of concern in looking at this question. The first has to do with reproductive rights, the welfare of offspring, issues of non-discrimination, and concerns about professional autonomy. So the key points, the key conclusions to our document: number one, transgender persons have the same interests as other persons in having access to care for fertility preservation and reproduction. The Ethics Committee concluded that current data, both medical and psychosocial, are sparse, but they do not support restricting access to ART for transgender patients. They do not support concerns that children are harmed from having transgender parents. And finally, in conclusion, that denial of fertility care to transgender persons is not justified. The committee also made some recommendations for providers. It is our belief that providers should treat all requests for ART without regard to gender identity, should offer fertility preservation when requested, and we want providers to provide appropriate referrals if they do not have sufficient resources to provide the care themselves. Providers also need to inform transgender patients about any known medical risks and the lack of data about long-term outcomes for both the parent and the child. And we hope that increasingly providers will be able to collaborate on collecting outcome data. So let's go back a second. What does the term transgender mean? Transgender refers to people whose internal sense of being male or female differs from the gender they were assigned at birth. The official term for this experience is called gender dysphoria. Transgender persons report intense and persistent discomfort with their primary and secondary sex characteristics, which they have often described as being trapped in the wrong body. Transgender persons describe a long-standing desire to change their physical appearance and presentation to bring it in line with their experienced or gender identity. It is worth noting also that this experience can appear in childhood and persist well into adulthood. Transgender persons typically choose to change their presentation to match their internal sense of being male or female. There are various options for making this transition. Some patients will choose complete sexual reassignment or gender reassignment surgery, which interestingly enough is increasingly being paid for by both U.S. government insurance policies and private health insurance policies. Some patients will take hormones without surgery, and others will undergo a combination of taking hormones with partial surgery, such as breast removal. This is a trans man or a female to male transgender person named Thomas Beatty. He kept his reproductive organs during the transition and went on to have 3 full-term pregnancies, becoming the father of 3 children. This is formerly Bruce and now Caitlyn Jenner, an example of a male to female or trans woman. The last 2 decades have witnessed new directions in research about transgender identity, moving away from our previous focus on pathology. Our current thinking, which is shared by several professional organizations, is that gender dysphoria is not by itself pathological and does not qualify as a mental disorder. The research we have to date shows that persons with gender dysphoria do not demonstrate higher rates of psychopathology, and we know from years of previous attempts that transgender identity cannot be, quote, cured. Finally, we know from data that patients who undergo sex reassignment show a relatively low level of psychopathology. What is the etiology of gender dysphoria? Why are people this way? Honestly, we don't really know. The etiology is poorly understood, but it's agreed at this point that biological elements, genetics, prenatal influences, hormonal influences, and environmental factors may all play a role. There is no single reason. We do know that gender variant behavior has been documented in many cultures from antiquity forward. The research about transgender persons is very clear that transgender persons can be highly educated, stably employed, sustain long-term partnered relationships, and report a high level of social support. Transgender patients come from all races, sexual orientations, and socioeconomic status. This is a photo of Phyllis Fry, the first openly transgender judge. Before her transition, she was Philip Fry, husband, father, born-again Christian, former Eagle Scout, former Army lieutenant, and had a master's in mechanical engineering. She came out in 1976 and commented, quote, "I have felt normal for the first time in 28 years. Previously, transgender patients have assumed that sterility or non-reproduction was the price to pay for transition. In the past, ART programs have received requests for fertility treatment or preservation, but they have varied in their acceptance of such patients. It is our belief that transgender persons wish to have children for the same reasons as any other person, and that research from Europe shows that high percentages of transgender persons of reproductive age wish to have either more children or a child after transition. Recognizing that transgender persons face discrimination in many aspects of life, including healthcare, professional organizations have begun to incorporate anti-discrimination clauses into policy and ethics statements. 2 notable ones are from the American College of Obstetrics and Gynecology and the American Medical Association. For our members, I think the last point is quite important, and that is that any physicians who offer their services to the public may not decline to accept patients because of gender identity. We have some early research about the children of transgender parents, most of which took place with children who knew their parents during the transition to a different gender. There is no evidence of gender identity, gender role disturbance, sexual disturbance from children raised with transgender parents. Green looked at one group in 1978, another group in 1998. He had the same results for both groups of children. What was notable about his research is that all of these children had an attachment to their transgender parent and wished to maintain a close relationship with that parent. Friedman and co-authors examined the development and mental health of 18 British children with transgender parents, most of whom had been born, again, before their parents' transition. None of these children exhibited gender dysphoria. None of them displayed significant psychosocial problems, and any difficulties in family relationships they had were really due to the high levels of conflict between the transgender and non-transgender parent. So while recognizing that offspring welfare is a valid consideration for fertility programs, it is also important to remember that children can prosper in a wide variety of families, that all of the psychological research we have affirms that the key factor is the parent's ability to bond with the child and the child's attachment to the parents. And finally, it's difficult to make accurate predictions about parental-child rearing. In conclusion, absent other facts, transgender status cannot be the basis for the denial of treatment. Thank you. Please submit any questions via the little chat box at the right-hand corner of your screen, and they will be answered at the end. Thank you.
Hi, everybody. Hopefully you can hear me. This is Paula Amato. Thanks, Judy, for the introduction. Thanks to the ASRM. Thank you to the ASRM Ethics Committee for inviting me to participate and for holding this webinar on this important topic. What I'd like to do during my few minutes is talk about the impact of gender transition on fertility, and then discuss the fertility preservation and reproductive options for transgender persons. So as Jean said, many transgender persons desire to have children. In one survey, 62% of trans men expressed a desire to have children at some point in their lives. And the majority of transgender persons are of reproductive age when they undergo transition. We do know that cross-hormone therapy and sex reassignment surgery can have an impact on fertility. This is in some cases irreversible, such as with gonadectomy, and in some cases reversible, as with cross-hormone therapy. Okay, I'd like to present a couple of cases just to give you an example of the type of patients you might encounter if you do provide fertility services to this population. This is a 14-year-old trans male that was referred to me by his pediatrician to discuss fertility preservation options. He was planning to start GnRH analog for pubertal suppression and subsequently go on testosterone therapy. So we had a conversation about the options of oocyte cryopreservation, and I briefly mentioned the possibility of perhaps freezing ovarian tissue in the future if he were to choose to undergo an oophorectomy at some point. So this type of counseling is not dissimilar from the type of counseling we would normally do with a young girl who's about to undergo gonadotoxic chemotherapy for cancer treatment, for example. The second case is a couple who presented a 35-year-old woman with her trans male partner. He had been on testosterone for a number of years, and they were interested in undergoing what we call reciprocal or co-IVF. They wanted to use his eggs, fertilized in this case with directed donor sperm, and then have the embryo transferred into the female partner's uterus. So he discontinued his testosterone therapy. We waited for his menses to return, and then he underwent ovarian stimulation and egg retrieval The eggs were fertilized with donor sperm, and then the embryo was transferred into his female partner's uterus. She subsequently conceived and went on to deliver a healthy baby. Both the World Professional Association of Transgender Health, or WPATH, and the Endocrine Society recommend that all transgender patients be counseled regarding fertility preservation options, ideally prior to transition. Fertility preservation post-transition requires discontinuation of exogenous hormone. I should say that data on the outcomes of fertility preservation in this specific population is lacking, and the data that we do have is mainly extrapolated from our experience with fertility preservation for cancer patients or for patients undergoing elective fertility preservation. The fertility preservation options for trans women include sperm cryopreservation, again, ideally prior to transition or after discontinuation of estrogen therapy, if after transition. In cases where ejaculation is not desired or possible, then testicular sperm extraction is a well-established option. At this point, testicular tissue cryopreservation in prepubertal boys is considered experimental and not currently recommended. The fertility preservation options for trans men include oocyte and/or embryo cryopreservation if the patient is willing to fertilize his eggs with either partner sperm or donor sperm. We do know that the success rates are slightly higher with embryo cryopreservation than with oocyte cryopreservation, although the success rates with oocyte cryopreservation have improved markedly in the last several years. Ovarian tissue cryopreservation is still considered experimental. There have been approximately 40 live births from this technique, but all these cases involve transplanting the ovarian tissue back into the patient, and this would presumably be undesirable for a trans man. It may be that in the future we might be able to in vitro mature oocytes from this cryopreserved ovarian tissue, but again, this remains experimental at this point. The reproductive options for transgender persons, again, usually require discontinuation of exogenous hormone unless you have gametes that were cryopreserved prior to transition. How long to discontinue the hormones is a matter of debate. In our patients who discontinue testosterone, we wait until menses resume. The time to return to fertility is variable and in some cases is irreversible. Once the patient discontinues hormones, however, the risks of the treatments, namely ovarian stimulation and egg retrieval, for example, are expected to be similar to the transgender patient as they are with cisgender patients. However, I do counsel my patients that we have no data really on the impact of a long-term history of exogenous hormone exposure to the gametes or to children resulting from these gametes. The reproductive options for trans men include intrauterine insemination with either partner sperm or donor sperm, or in vitro fertilization using patient's eggs or partner's eggs and/or patient's uterus or the partner's uterus or gestational carrier. The reproductive options for trans women include intrauterine insemination of a female partner using the patient's sperm, or IVF using either partner eggs or donor eggs and/or the partner's uterus or gestational carrier. Whether or not uterine transplantation would be feasible in the future is unclear. The first reported case was reported in Europe or Sweden, I believe, about a year ago. In a cisgender woman, it's not expected that this procedure would be widely used, at least not in the United States. Just a reminder that if you are using donor sperm or donor egg or a gestational carrier, the ASRM and FDA have published guidelines regarding sexually transmitted disease screening, and all parties involved should be offered psychological counseling as well. As I said, we don't have a lot of data on this specific population in terms of outcome. There was one study published just over a year ago, which was a web-based survey of 41 trans men who became pregnant after undergoing transition. 61% of them had used testosterone. 80% of them resumed menstruating within 6 months of discontinuing the testosterone. 88% of cases used their own eggs. 2/3 of the pregnancies were planned, which underscores the need for contraception in some of these patients. 7% used fertility medications, and at least according to self-report, the obstetrical outcomes were similar in patients who had used testosterone and non-testosterone users. They did express a desire for more targeted supported resources, and they did comment as well on the lack of provider awareness and knowledge regarding transgender care. As far as access, again, we don't have data specifically on the transgender population. Non-discrimination laws do vary by jurisdiction and by state, and Judy will talk about that. These treatments, of course, can be expensive and are rarely covered by insurance, but obviously financial barriers are an issue for all our patients, not just transgender patients. So in summary, many transgender persons desire children and are of reproductive age at the time of transition. We believe that transgender persons should be offered fertility preservation, ideally prior to transitioning, and that they should have access to fertility services. Ideally, a multidisciplinary team approach is recommended, and we encourage research in this population to gather more data so that we may be better able to counsel this population. I'd like to leave you with a few resources. Both WPATH and the Endocrine Society published guidelines on transgender care, and there are 2 trans-specific clinics, one at UCSF and one in Vancouver, British Columbia, that have a number of very valuable resources on their websites. Thank you, and I'd be happy to take questions at the end.
Well, thank you, everyone. I hope that my slides are showing, and thank you to Jean and Paula so far for those wonderful presentations. So I'm going to speak about the legal aspects of this particular topic, and as you can see, we are required to provide our disclosures. I'm also going to move along to the learning objectives, and this really is isolated to my portion of the presentation. But my goals are to provide the group with really a framework for understanding the legal aspects of care in this patient population. And I'm really going to focus my remarks on the civil rights rubric, and I'll explain how that plays out in the United States. I'm going to move from the civil rights rubric to talk about the obligations that providers have under law to deliver care, and talk about a few cases in which these obligations have been tested out. And then finally, at the end, I'll briefly talk about other issues that patients might experience in the legal realm, particularly with respect to questions of parentage. And as just a slight disclaimer, I will say that for the providers on the call, this really does go beyond the scope of your professional responsibility to be familiar with family law, but it may be questions that come up, and at least you can have some familiarity with the way the law treats parentage in this area. So let's begin then with the basic civil rights framework for the United States. Now, we live in a federalist system, which means that we have laws that govern at both the national level as well as at the state level. And the relationship between federal law and state law can be very important in the civil rights arena. Now, from the federal perspective, the Federal Civil Rights Act is in its 6th decade. Enacted initially in 1964, it was very limited, or we could say from our 2015 perspective, it's quite limited in what it covers. But it remains really the major civil rights legislation that governs the private relationships in a variety of arenas, including the healthcare arena. So the civil rights laws at the federal level do interact with healthcare delivery, and the way they do at the federal level is through the Civil Rights Act and a particular provision within that, which is known as Title VI. And Title VI is a very broad and general provision that basically says that any individual or institution that receives federal assistance, federal funding, cannot discriminate on the basis of a series of factors, and here you see them: race, color, national origin. And if you think about that in today's world, those categories are extremely limited. That is, we now know that discrimination can occur in a variety of other ways based on sex, clearly not in the 1964 Act, disability, sexual orientation, and what we're speaking about today, gender identity. So the civil rights laws at the national level do not protect against those classifications. And the writing on the Civil Rights Act over the last 50 years has suggested that even in the categories to which it does apply, it's of limited usefulness to plaintiffs or patients in our case, because there are very high thresholds of proof. In some cases, intentional discrimination must be proved by the plaintiff. And then, as I said, the limited number of categories also really rules out a number of plaintiffs or patients moving forward if they face discrimination by their healthcare provider. Recently, the Affordable Care Act, some dub it Obamacare, which we now know was enacted in 2010, has been with us for a number of years, did take into account the need to further bolster discrimination in the provision of health care on a variety of bases. And as you can see, the Affordable Care Act does prohibit sex discrimination by providers receiving federal funds. So to the extent there was a gap or a hole in Title VI, the ACA really fills that, but only with respect to sex discrimination. Now, other cases and regulatory structures have interpreted the sex discrimination category as applying to the LGBT population, including transgender patients. So the Affordable Care Act does address this population with respect to discrimination in the provision of health care. However, there are, of course, drawbacks and frailties to the ACA. For example, transgender care, transition, fertility treatment is not a minimum health benefit. It's not required to be covered by the insurance plans or the exchanges that were established by the ACA. So while it may help perhaps theoretically or even practically with respect to discrimination, it does not help in any way financially with respect to the treatments that we've been talking about today. And of course, Paula mentioned, and we're all aware of the access issues that all of our patients experience in the ART arena. All right, moving along to the state laws. The federal laws create what I would call a floor. That is, that they create minimal standards for protection for patients that meet certain categorization. But the states are not limited to those protections, and in fact, they can go above. They can create their own ceilings, if you will, for protection within their borders. And many states have taken advantage of this opportunity and have adopted additional civil rights protections for LGBT patients. And here I just have some demographics about what the law looks like across the United States. So about half of the states in the U.S. Do prohibit discrimination in public accommodations, which does include medical facilities, on the basis of marital status. And this is where the first groundbreaking efforts toward recognizing relationships as a potential cause for discrimination gained traction. About a third of the states now also include discrimination laws that prohibit conduct that's based on sexual orientation. We're starting to see a little bit of movement in the gender identity arena, but not nearly as many states have added gender identity as a protected class. But some have, and I expect to see that others will moving forward. So it's a bit of a checkerboard, which is what my map is showing. And so it depends a great deal on where you live, whether as a patient or a potential plaintiff, you would have any protection based on your gender identity. All right, well, let's move on. Let's say that you're a provider in a state that does have protection against discrimination on the basis of gender identity by healthcare providers. Well, what does that mean exactly? And I think importantly for this group, what does that mean for providers? Let's imagine that the patients that Paula described came to see a provider. There's a number of possibilities that the provider could offer to the patient, and I've just tried to capture 4 of them. So let's say that the provider gave any of these 4 responses. Let's talk about what they mean. So one response would be that the provider would provide care to the patient to the best level of care and skill that the provider had. So that's by way of saying that if the provider feels that he or she does not have sufficient knowledge or background to provide care, then that might be a reasonable basis to decline. But I caution, because at the same time, as Paula explained, the delivery of care is similar to care that's been delivered in the cancer fertility preservation scenario, although again understood by the legal standards that not all providers are familiar with this type of subspecialty. But one has to just be certain that their qualifications are truly not up to the standard of care to provide care in order to refuse to treat a patient on that basis alone. Second, a provider might impose barriers that are not similarly placed upon non-transgender patients. And I'm going to talk in a minute about a case on the East Coast in which this did happen, and you'll see the outcome. So in other words, that patient was confronted with additional requirements for accessing treatment that the patient discovered were not similarly imposed on non-transgender patients. All right, third, a provider could refuse to provide care due to a lack of appropriate care and skill. And as I said with the first bullet point, that is typically a question of fact, and it would have to be, if there were some legal proceeding, it would have to be shown that this in fact was a good faith assertion of an inability or unwillingness to treat. And so providers just need to be aware of this factual inquiry. And then finally, a provider might simply refuse to provide care for discriminatory reasons, just to say that I won't provide care because I don't find that I want to assist you in your family formation. I'll also show you a case in which this occurred, and I'll talk about the outcome. So those are some possible conversations that might occur at the bedside when care is sought. All right, let's take a look at one of those responses. And here you see a photograph of Andy Inkster, who transitioned when he was about roughly 18 years old. And when he was in his 20s, he sought fertility treatment at a clinic that was fairly nearby where he was going to school in the state of Massachusetts. Now, the facts that I'm providing for you come from Andy. So they have not been vetted by a jury. They have not been declared by a court. So I just want to say that these are what we might call allegations because there is no finding of fact. But the story that Andy tells goes as follows. He said that the physicians, upon meeting him, said that he was, quote, too masculine to be a parent. And in addition, they required that he provide evidence of his mental health ability to be a parent, that he needed to show from evidence supplied by his therapist that he had the emotional and psychological well-being to go ahead and proceed with parenthood. And he claims that no such requirements were made of other patients in the reproductive medicine specialty practice, and probably that was the case, although again, we don't have the facts on that. So as you see from my bullet point, in this case, the clinic did refuse to provide care to Andy. He subsequently traveled several hours from his home and did access care at another facility, and you see him there with his daughter. She's now roughly 5 years old. So he was able to fulfill his family formation goals, but only after undergoing this kind of treatment and then burdens of travel and expense associated with his care. Now he is asking the Massachusetts Commission on Discrimination, which is the state authority in the state in which this occurred, to pursue a claim against the original clinic. And my most recent research indicates that last year the Commission found what's known as probable cause of discrimination, which allows him to pursue a claim against the clinic. I have not been able to find out whether it was resolved or how it was resolved, so I can't give you the end of the story, but I think it's sufficient to say that he was able to bring a claim that at least this commission deemed as viable and proceed against the clinic. Another story involves a California couple, and the case now took place many years ago because you can see it was decided in 2008, but the facts predated that by several years. And you see pictured the couple that was at the heart of this case with their 3 children. But initially, the woman you see on the right, Lupita Benitez, she sought care at a San Diego area clinic where her private insurance actually did cover ART. And again, just like in the case of Andy Inkster, I have to caution that these are allegations. This case was never actually heard by a jury or a court, so we don't know what the findings of fact are, but the complaint that's filled out by the plaintiff provides the following story, that Lupita and her partner Joanna did together approach the physicians at this clinic and were told that the physicians' religious beliefs really prevented them from providing care. Now, this is clearly not a transgender scenario. It involves a lesbian couple, but I think the law would speak equally if that were the situation. Well, after they were declined care at the clinic, as you can see, they did go to another clinic and successfully build their family. But the case that they brought is really the first of its kind and remains the only case at a state high court level to decide the preemptiveness of a provider's religious freedom against the rights of a patient to be free from discrimination on a particular basis. And a unanimous California Supreme Court said, as you see from my bullet point, that the right of religious freedom from the physicians does not exempt them from complying with what our UNRRA is, our state civil rights laws, which do prohibit discrimination based on a patient's sexual orientation. So the couple did prevail in that case, and the court was very strong in saying that physicians must adhere to what are called valid and neutral laws of general applicability, and those certainly include civil rights laws. All right, just moving along, what about minor patients? Again, Paula mentioned this, and it wouldn't be unusual for minors to approach you in your practice. So what are your duties and what are the legal parameters of providing care to minors? And just a few points to talk about. First of all, generally speaking, all treatment for minors require parent or guardian consent. But I do want to add that the assertion of a reproductive rights related treatment might change that calculus. And I only know this through reasoning by analogy. I don't know this by actual law or statute. So that is to say that, as you probably are familiar, the reproductive rights landscape includes disagreement among states about the rights of minors to access abortion and contraception. So their rights to avoid pregnancy through abortion and contraception are sometimes offered without the traditional requirements that parents be involved. So I'm just thinking that by analogy, it may be that minor patients who seek affirmatively to preserve their fertility might likewise be able to do so under a mature minor doctrine that doesn't include a parental consent. But this would be new legal landscape, but it is something worth thinking about. In most situations, minors would be asked to assent along with parental consent, and so that would ensure that the informed consent process was complete. And as Jean mentioned, and I think Paul as well, our document does recommend delaying surgeries until adulthood because of the experimental nature of them, even though that may be a preferred option for minor patients. That's the recommendations of the Ethics Committee. And then I saw this statement by the UCSF Center for Transgender Health, which seems somewhat ominous in terms of the fertility options, in which they say the use of prolonged cross-sex hormones will make biologic children very unlikely for transgender youth in the future, although I think some of the data is suggesting perhaps that may not be the case. And of course, the informed consent process, the risks and benefits is critical to treating minor patients. And then finally, my last slide takes us to the family law arena. And this is Thomas Beatty, who Jean mentioned. You see him here about 5 months along. And one of the issues that I thought would be interesting to tease out, and perhaps we can do this in the Q&A, is can one person be legally considered to be both a mother and a father? Well, under law, the answer is probably yes, but would actually result in these two case scenarios. So a male to female, so a female banks his sperm, or her sperm, sorry, prior to transition, and then at the time of reproductive desire, hires an egg donor and a gestational carrier to carry her genetic child. So in that case, she would be both the intended mother, which is a calculus very familiar to gestational surrogacy, but also the genetic father. Now, normally, a donor in a gestational carrier scenario would not be listed as the father, but here there may be a desire to list that person as the genetic father. And then, of course, the flip side is the female to male stops wants to begin menstruating after IUI with donor sperm carries the baby to term. So again, under most states' law, this person would be the mother because many states' law define motherhood by giving birth, but also there's opportunity for fatherhood by genetics. These days, most birth certificates do not say mother or father, they say parent 1 and parent 2. But query, could one individual place themselves in the same both times as parent 1 and parent 2? I'm not aware that has ever happened. I'm not aware that that request has been forthcoming, but I thought I'd leave you in my final slide with something interesting to contemplate as we go into the question period. So with this, I'll wrap up my portion, and I think Jessica is going to take the microphone back, and she will take the questions to the appropriate speaker, and we'll go ahead and answer as many as we can. Thanks, everyone, so much.
Thank you for speaking, Professor Dar. The first question is actually for you, and I've left you in control of the slides. One of the attendees wanted to know what the different colors on your map represented. If you would go back to that slide and show it again and explain the colors.
I don't think that this was an accurate slide today of the gender identity. If I remember, this one was looking at sexual orientation, discrimination provisions, and I have to say I'm not recalling what the 3 colors represent, but I'd be happy to look into that and get back to the caller.
Thank you very much.
Okay.
The next question is for Dr. Amato. How long would you recommend stopping testosterone before ovarian stimulation?
That's a good question, and we actually don't have any data, except for, that one study that I showed that most trans men, when they stop testosterone, will resume menstruating within 6 months. And as you can imagine, having a period after many years of testosterone treatment is disconcerting for many trans men. So our policy in our clinic is as soon as they start menstruating, we begin the IVF process. And whether or not there needs to be a so-called washout period of that testosterone in terms of effects on the gametes, specifically the oocytes, is not clear, but our current policy is to try and minimize the time off of testosterone as much as possible.
Thank you. This next question is for Ms. Benward. Are there any different recommendations for psychological consultation when working with a trans person who may need third party?
Thank you for that question. I'm going to address it in 3 parts. The first part is mental health professionals should be part of an interdisciplinary team providing care to transgender patients. Secondly, we don't know very much about the counseling needs or desires of transgender parents. There's very little research. I would imagine one of their needs is to be treated fairly and without discrimination. I think transgender patients, more than other groups at this point, come in somewhat wary of how they're going to be viewed by the mental health professional, and I don't think we can approach them with an assumption that, again, there's some pathology that we have to assess. I do think that some of the things that come up in my counseling sessions with transgender patients are explaining their transgender status, even when the children are born afterwards. A father, for example, may not have all the anatomical parts associated with being a father. Then there's the question of how to discuss assisted conception. There's the question of disclosure to whom, when, how. So again, some of the issues in the consultation are going to be very similar to what you will cover with other kinds of patients. I think there's a great need for resources for trans parents, and I think we could all do our patients a service by trying to track those down. Thank you.
Thank you very much. This next question is again for Dr. Amato. What are the options for transgender patients who underwent pubertal suppression with GRNH analog as children without initiation of puberty?
This, to me, represents the most challenging scenario. As people are transitioning at younger and younger ages, often now they're not undergoing puberty at all. So in terms of fertility preservation or reproductive options, currently the only option is to discontinue the pubertal suppression and the exogenous hormone therapy for that patient to undergo puberty and the non-desired gender, and then undergo the fertility preservation reproductive options that I spoke about. Whether or not it would be possible to freeze either testicular tissue or ovarian tissue prior to puberty and then successfully get mature gametes from that tissue that would result in a pregnancy is unclear at this point. That may be possible in the future, but it's not currently possible.
Thank you. Again, for Ms. Benward, should all transgender patients have psychological evaluation before proceeding to fertility care?
I don't think transgender patients should be treated differently than other patients who need ART. For example, if the couple will be using donor gametes and a practice requires all recipients to have a consultation, then the answer would be yes, because it's consistent with practice policy. As Judith pointed out, it's important to not create situations in which we single transgender patients out for different treatment. And I also have to say, based on my experience, that this group of potential parents are extremely well prepared. They're probably among the most prepared group of patients. They have given a great deal of thought to this. They have looked at it from all angles and probably know as much, if not more, about handling transgender parenting than we do. Thank you.
Oh, thank you. This next question is for any panelist who'd like to answer it. Are there any specific guidelines or recommendations for adapting our patient intake and consent forms to suit the transgender patient?
That's a great question.
Okay. Go ahead, Professor Dar.
I was going to say that's a great question, and it may be one that, as a practical matter, we could pass on to the SART-informed consent committee, which I am on, and so I'm happy to do that, because we have been working over the past now about 4 years to develop forms that could be useful globally for practices. And frankly, this is not something that we have considered, but it might be actually quite a good idea to go ahead and think about that.
Jessica, this is Jean. There's a recent article that I have that talked about how to change intake forms to make them more suitable for transgender patients, and I can forward that article to you, and you could forward it on to whoever's interested.
I would be very happy to do that. Please do.
Okay.
And Jessica, this is Paula. I'd just like to add that a number of organizations also have resources that can help with cultural competency training, and those would include the Gay and Lesbian Medical Association, the Fenway Institute, Human Rights Campaign, who else? National Center for Lesbian Rights, and WPATH. Many of those organizations would have those types of resources.
Dr. Amato, if you would make a list of those resources, I'd be happy to embed that in the recording that we will be posting on the website as an additional resource.
Okay, will do.
This next question is actually also for Dr. Amato. Does the prolonged use of testosterone affect oocytes that we know of?
We honestly don't know the answer to that question, and I'm honest with my patients and I tell them we don't know because there's lack of data in this area. I can tell you from my own anecdotal experience, ovarian reserve in these patients has varied. Some patients have very good ovarian reserve and some don't after years of testosterone therapy. So whether there are any short-term or long-term effects of long-term testosterone exposure, we don't know.
Thank you. And the last question is actually for anyone who can answer, and that is, are fertility preservation services typically covered by insurance?
I think I can answer that. I think typically the answer is no. That there are a lot of advocacy groups that are trying to convert treatment to be paid, but in the main, just like ART or IVF is not covered roughly 85% of the time. Likewise, fertility preservation in this population is generally not covered by private or public health insurance.
Oh, thank you. I did have a follow-up question to that, and that is fertility preservation for transgender different than fertility preservation for cancer in terms of insurance coverage?
Not that I'm aware of.
Thank you. With no more questions in the chat window, I'd like to thank our wonderful presenters and thank our attendees for joining us today. Please watch for an announcement of the posting of a recording of this webinar on our website in the near future. Thank you.
Thank you.